Now, welcome to the topic of nerve injuries, a very, very important topic for your NEET PG and INI set exam. Now, not only for these exams, I feel it is a very important topic for any kind of medical exam that you're appearing for, whether it's national or international. And the reason for this is one topic where the examiner gets to play integrating the knowledge of your anatomy with a clinical presentation in orthopedics. So, examiner enjoys framing questions around this because it will turn and twist the basic simple facts to get the answer. Now, if you're not very good at your anatomy, you will be struggling in this topic without a doubt. There is absolutely no doubt about it. But I will try to review the anatomy as much as possible, trying to explain the nerve, its motor and sensory supply, and what will happen if the nerve gets injured. But I request you, or rather urge you, to go back to anatomy and review the course of these nerves, review the muscle and sensory distribution of these nerves, so that when I talk about it, it becomes a revision and you understand the clinical points about the nerve and its injuries. See, the point I'm trying to make here is I'm an orthopedic surgeon and I will teach you anatomy in terms of the clinical requirement in treating a patient of any problem in orthopedics. Whereas the anatomy faculty would have done a very great job in teaching you the anatomy in terms of the relations and the specific supply of the nerve for muscles. Now, there will be many muscles supplied by a particular nerve, which I may not be interested in terms of a clinician. I will be only interested in 2 or 3 muscles because they will help me make the diagnosis of the site or location of injury, and they will help me decide the treatment plan. So whatever I will teach you of the anatomy in nerve injuries will be heavily focused on the clinical aspect of anatomy. With that said, review the anatomy and then come back to this, and trust me, you will enjoy this topic. Otherwise, it will be a little bit of struggle, but nevertheless, I will still try to make it easy for you. Okay, so first thing I want to understand is what is the structure of the nerve. So basically, we need to talk about the ultrastructure of the nerve, the various sheaths surrounding the nerve. Why is this important? Because we will be talking about the classification of nerve injuries, and only when you understand the structure of the nerve, you will be able to understand the classification of nerve injuries. Now, why do we need to know the classification? Because that will help us understand the management of nerve injuries. Okay? So please look at this. This is a section, a cross-section of a typical nerve. What do you find? At the center of our interest is axon. Okay. Now, each axon will be surrounded by a sheath known as endoneurium. Okay. It will be surrounded by a sheath known as endoneurium. Now, many such axons with their respective endoneuriums will again be surrounded by another sheath known as perineurium. Look at this. Axons with their endoneuriums. Axons with their endoneuriums. Now let's look at the ultrastructure of the nerve. At the center of our interest, we have something known as an axon. For example, this is an axon. I'm showing you the cross section. Okay, this is an axon. Each axon is surrounded by another sheath known as endoneurium. So each axon is surrounded by another sheath known as endoneurium. Okay, now there are many such axons with their endoneuriums again surrounded by another sheath known as perineurium. Now, this is what is known as a fascicle. So what is a fascicle? A fascicle is a perineurium. Underneath, you have multiple axons surrounded by their endoneurium. That is a fascicle. Now, there are many such fascicles together surrounded by another sheath known as epineurium. Okay, so outside you have epineurium, then you have perineurium, then you have endoneurium, and then you have your axon. Now, what is this? Why do we need to understand this? So let me show you this. So this is your axon. At the center of our interest, we have axon. Each axon is surrounded by endoneurium. Okay. And there are many such axons with their respective endoneuriums is surrounded by perineurium. This is what is a fascicle. And many such fascicles are again together surrounded by another sheath known as epineurium. Right. So this is our typical structure of the nerve. Now, why is this important? This is important because suppose there is a nerve injury. Suppose there is a nerve injury. What happens? For example, there is a nerve injury here like this. What happens to the distal limb? Distal limb. Why am I calling it the distal limb? Because suppose here is the receptor and here is the cell body. Okay, so this is the distal limb, the cell body side is the proximal. So suppose there is a nerve injury. What happens to the nerve? The distal limb of the nerve will undergo what is known as Wallerian degeneration. You know this from your basics. It undergoes Wallerian degeneration. It degenerates. Now what happens to the proximal limb? The proximal limb attempts to regenerate. How does it attempt to regenerate? By throwing out sprouts of naked nerve endings. Okay, it throws out sprouts of naked nerve endings. This bundle of sprouts of naked nerve endings is what is known as your neuroma. Okay, listen to me. Everything I have prepared PPT. The slides are written. I want you to understand first, then you can write it down. Please understand. Okay, please bear with me. Understand first, and then you can write down for the rest of your life. Understand first. So this bundle of naked nerve endings or the naked nerve sprouts is what is known as your neuroma. Right? Now, since the sheaths around the injured axon are intact, or at least any one sheath around the injured axon, if intact, will lead the regeneration of this neuroma towards the receptor. It will slowly regenerate at the rate of 1 millimeter per day. This is important. 1 millimeter per day. You will write down everything. Just bear with me. It will regenerate at the rate of 1 millimeter per day. Okay. Now, since this neuroma is surrounded by sheaths, we call it neuroma in continuity. We call it a neuroma in continuity because it is in the continuity of the nerve. Okay, it's in the continuity of the nerve. Now, this neuroma in continuity will eventually regenerate and reach the terminal part of the nerve. So, it will recover. So, this is a neuroma in continuity. The regeneration is at the rate of 1 millimeter per day. Only the axon or a few sheaths were injured, but at least one sheath should remain intact for this to happen. Now, what if the injury was such that all the sheaths with the axon were injured? All the sheaths with the axon were injured. What will happen? Same thing will happen. The distal fragment of the axon will undergo what is known as your Wallerian degeneration. It will undergo what is known as your Wallerian degeneration. Now, what will happen to the proximal limb of the axon? The proximal limb of the axon will again throw out naked nerve endings or sprouts in order for it to regenerate. But since there is no continuity of the nerve, what will happen? This neuroma will not be a neuroma in continuity. Instead, it will be an end neuroma because it is roughly at the end of the cut section. It's considered as the end neuroma. And this end neuroma will not regenerate. Okay, are you following me? That is the reason we need to understand this structure of the nerve, because it will help us understand the classification of the nerve injuries. Okay, so going back to this, what happens when the nerve is injured? I've told you, distal limb will go into Wallerian degeneration and the proximal limb will form sprouts of nerve endings, that is known as a neuroma. Neuroma, what did I tell you? That bundle of nerve sprouts, they regenerate at the rate of 1 millimeter per day. But the requirement is at least one sheath, that is the endo, peri or epineurium, should remain intact for it to regenerate. That is a neuroma in continuity. If all the sheaths are injured with the axon, we call it an end neuroma, and the end neuroma will not regenerate. The neuroma will remain where it is. Okay? Is that clear? Is that clear for you? You understood what are the structure of the nerve, what are the layers surrounding the axon, and what happens to the axon when it is injured. Okay. Now the next thing that we are going to talk about is Tinel sign. What is Tinel sign? So let me show you the diagrams here of the types of neuroma that we talked about. Neuroma in continuity is nothing but a bundle of naked nerve endings or the sprouts. The nerve at least still remains in continuity. That is why it is called a neuroma in continuity. Whereas in end neuroma, the nerve is completely injured. So the sprouts are not regenerating. This is end neuroma. Okay? Okay. Now, what is Tinel's test? What Tinel sign? See, neuromas are a bundle of naked nerve endings, right? So they will be very, very sensitive to any kind of stimuli. So in Tinel's test, this is what you do. You tap on the surface marking of a nerve. So you should know the anatomy or the landmark of the nerve. So you tap on the surface marking of the nerve. Normally, when you tap on the nerve, because it is surrounded by all the sheaths properly and it is normal in anatomy, the nerve will not get stimulated usually. Okay, it should not get stimulated just by tapping. Okay, hard percussion or using an object to stimulate it, it might stimulate the nerve. But normal tapping should not elicit any kind of stimulus because it is nicely surrounded by all the sheaths. Now, if there is a neuroma, which is nothing but a bundle of naked nerve endings or the sprouts, it is very, very sensitive to any kind of stimulus. Now, the moment you tap on the neuroma, the nerve will get stimulated and the patient will tell you that he is getting sensations distal to the tap. I'll explain this in a bit. I'll explain the law of projection just in a bit. Bear with me, you'll understand. So why is this happening? Because neuroma is a bundle of naked nerve endings which is easily stimulating by your tap. Okay, the moment you tap on it, the patient will tell you he's getting sensations. This is a positive Tinel's test. What is it? It is a positive Tinel's test. So look at this. Percussion from distal to proximal on the surface marking of the nerve. Nerve gets stimulated. When the nerve gets stimulated, the patient will say there is sensations distal to the neuroma. I'll explain in a bit why this happens. So for a positive Tinel, what is the requirement? Neuroma is a requirement. So neuroma is a requirement. Either it is a neuroma in continuity or end neuroma, doesn't matter. Wherever there is a neuroma, wherever there is a naked nerve ending bundle, there will be a positive Tinel. There will be a positive Tinel. Now listen to me very carefully. If it is an end neuroma, the neuroma is not going to regenerate, right? So if you repeat the Tinel test a few days, few weeks, few months later, it will become positive at the same location that was positive previously. Okay, so we call it a positive non-progressive Tinel. We call it a positive non-progressive Tinel, which will be seen in end neuroma. Is this clear? Are you with me? Are you following me? Right. Now, what if it was a neuroma in continuity? If you tap on the neuroma, it will be positive. But if you repeat the test a few days or few weeks or few months later, what will you notice? You will notice now that the neuroma is regenerating at the rate of 1 millimeter per day. The Tinels has become positive at a different location compared to when it was positive previously. We call this a positive and a progressive Tinel. So positive and progressive Tinel will be seen in neuroma in continuity. Positive and progressive will be seen in neuroma in continuity. And only positive without progressive and neuroma. So what is the requirement of a positive Tinel? Neuroma is a requirement. If it is positive, Tinel's positive means there is a neuroma. That's it. If it is progressive, it means neuroma in continuity. And if it's not progressive, it means the end neuroma. Okay? Clear hai? So this is a diagram showing you that you're tapping the nerve from distal to proximal. The moment there is a neuroma, the nerve will get stimulated. Now, the moment the nerve gets stimulated, the patient will tell you he's getting sensations distal to the neuroma. Now, why is this important? This is important because you see, the sensations should only reach the brain through the receptors. The sensations of any nerve should reach the brain through the receptors. They should not reach the brain between the nerve. Are you following me? For example, look at this. Say this is a nerve that is reaching your brain. And this is the receptor. For this sensation to reach the brain, this receptor has to be stimulated. Yes or no? For the sensation to reach the brain, this receptor has to be stimulated. Now, the nerve is injured here. There is a neuroma here. Now, moment you're tapping on the neuroma, the nerve is getting stimulated and the sensation is going to the brain. It is going to the brain. But the brain doesn't know that you're stimulating the nerve in the middle. It is still thinking that the receptor is getting stimulated because of law of projection. Because of law of projection. Your brain has already decided which nerve stimulation means which part of your body is getting stimulated. It's based on the projection of these receptors. Your brain has already decided if that receptor is stimulated, it means that part of the body is getting touched. But here what has happened, the nerve is injured. There is a neuroma here in the middle. And the moment the neuroma is getting stimulated, the brain is thinking that the stimulation is coming from the receptor. And so the patient will tell you that he's getting sensations in the area which did not have sensations previously after the nerve injury. Are you following? Samajh aaya? Suppose you have a nerve injury here. You will lose sensations here. But the moment you tap on the neuroma here, you will get sensations here because the nerve is getting stimulated. The brain is thinking that the nerve is getting stimulated from the receptor. This is the law of projection. It's not very important for you to understand, but it is so much fun to understand the beauty of nerves, right? Right. So this is Tinels. So you've understood what is a positive Tinel. Positive Tinel requirement is neuroma. 2 neuromas. Neuroma in continuity and neuroma. Neuroma in continuity, positive and progressive Tinel. And in neuroma, only positive, non-progressive Tinel. So far, so good. Okay? Everything you've understood? Now, let me ask you something next. Suppose there is a nerve here. Okay, let me draw the nerve. And it is supplying muscle number 1, muscle number 1, muscle number 2, muscle number 3. Okay, it is supplying 3 muscles, the nerve. This is the proximal part of the nerve. This is the distal part of the nerve. All right. Now, suppose you have an injury here. And this injury is such an injury where you have a neuromine continuity. Means only the axon with a few sheaths are injured, but at least one sheath has remained intact. You have a neuromine continuity here. Not an neuroma. We're talking about neuromine continuity only. Suppose there is a neuromine continuity here because of the injury. What will happen immediately following the injury, friends? Muscle number 1, 2 and 3 will lose their function. They will not be functioning anymore. So immediately after injury, 1, 2, 3 muscle will lose their function. Clear hai? Now, because it's a neuromine continuity, the nerve will regenerate. What is the rate of regeneration? 1 millimeter per day, right? So it will start regenerating. So which will be the first muscle to recover as it regenerates? Muscle number 1. Yes. Then muscle number 2. Then muscle number 3. So there is a progressive recovery of muscles from proximal to distal in a nerve injury where there is a neuromine continuity. Right? Yes. What is this known as, friends? This is known as motor march. So what is motor march? Recovery of nerve where there is a neuromine continuity. After injury, all the muscles are lost. Function is lost. But there is a gradual recovery of muscles from proximal to distal. From proximal to distal. Right? So this will only be seen when you have a neuroma in continuity. Clear? So far so good. Have you understood this term? Now, another thing I wanted to teach you. Look at this. Again, the nerve. This is a nerve, and this nerve is supplying again muscle number 1, muscle number 2, muscle number 3, muscle number 4. Okay. Now this nerve can get injured at 2 locations. Here, let's call this location A. Or here, let's call this location B. Now tell me, out of these 2 locations, which injury will give you more deformity and disability? Just think logically. Which injury will give you more disability and deformity? Yes, it is A. Why is it A? Because if there is injury at B, only muscle number 4 will lose its function. 1, 2, 3 will be fine. But if there is injury here at A, 1, 2, 3 and 4, all of them will lose their function. So in simpler terms, high injury or more proximal the injury, more the disability or deformity. And low injury or more distal the injury, less disability or deformity. Don't write down. Listen, everything you can write down. I have the PPT ready for you. Now look at this. High injury or more proximal the injury, more the disability or deformity. And lower injury or more distal the nerve injury, lesser the disability or deformity. So have you followed all of these basic things that I've just talked about? These are all rational, simple, basic things here. Right? So far so good. Now moving on to a little more advanced part, the classification of nerve injuries. Now coming to the classification of nerve injuries. Now you have 2 important classes. There are many classifications, friends, but 2 important for your exam. Okay? Seddon and Sunderland. Okay? Now they are different, but I'll make it simple for you so that they look the same to you. Right? So what is Seddon and Sunderland's classification and how are they classified? They are still classified based on the structure of the nerve that we have talked about. Axon, endo, peri, epineurium, neuromas, neuromine continuity and neuroma. Now everything will start to fall into place. Okay. So Seddon has basically classified it into 3 types, whereas Sunderland has many types. So for simplicity, Seddon has 3 types, that is neuropraxia, axonotomesis and neurotomesis. Okay. Neuropraxia, axonotomesis and neurotomesis. This is your Seddon's classification. Sunderland has 1, 2, 3, 4 and 5. Okay. Now listen to me very carefully. Neuropraxia is nothing but Sunderland 1. And neurotomesis is nothing but Sunderland 5. The problem is Sunderland 2, 3 and 4. Sunderland 2, 3 and 4 match with axonotomesis. Okay? Now let's look at how. Look at this carefully. This is the normal nerve. Normal nerve means what do you have at the center? You have axon. Each axon is surrounded by endoneurium and perineurium. And then there is epineurium. Okay, this is a simple line diagram for simplicity. Otherwise, axon is surrounded by endo, many such axons with endo surrounded by peri, and many such peri surrounded by epineurium. right? You know that. But for simplicity of understanding, axon at the center, endo, peri, epi. Axon at the center, endo, peri, epi. Right. Now, what happens here in neuropraxia? In neuropraxia, there is an injury, but there is no anatomical injury. It's a temporary physiological conduction block that occurs because of compression of the nerve against a hard or a firm object. Did you follow? So there is a nerve, and that nerve is getting compressed against a hard or firm object for a long duration, because of which the nerve is not functioning temporarily. Temporarily, there is a physiological conduction block. Anatomically, nerve is absolutely fine. Okay, so it's a temporary, physiological, reversible conduction block due to compression. That's it. So can you imagine sitting on a chair for a very long time? What will happen? You will feel tingling and numbness in your lower limb. Do you panic? Do you get amputated? No, you wait, you relax. It will recover, right? It will recover. How? It will recover spontaneously. It will recover spontaneously, right? That's how it happens. Recovery will be spontaneous and it will be 100%. It will be 100. The longest durations it will take is a few months. That's it. Not more than that. This usually happens whenever you apply a tourniquet or whenever you compress a nerve against a hard or a firm object. For example, Saturday night palsy. What is Saturday night palsy? Saturday night palsy, usually people get drunk, intoxicated, and they sleep on the bar chair, compressing the radial nerve on the backrest of the chair. And when they get up in the morning, because of this firm object compressing the radial nerve throughout the night, it undergoes neuropraxia, and when they get up in the morning, it doesn't function. The radial nerve doesn't function. So the radial nerve supplies the extensors of your elbow, wrist and fingers, and since the nerve is getting compressed in the arm, the elbow extensors would usually be spared, only the wrist and finger and thumb extensors would be affected. We'll read about this in detail later. And so the patient in the morning will have difficulty extending the wrist drop, Saturday night palsy. Another example would be crutch palsy, where people use axillary crutches improperly, which again compresses the radial nerve, and the patient would have wrist drop. Tourniquet palsy. Orthopedic surgeons use tourniquets to minimize blood loss, and if this tourniquet is applied too tightly or for very long duration, the nerves are compressed under the tourniquet and cause neuropraxia. Okay, everything is written. Temporary, reversible physiological conduction block. Recovery is spontaneous. It will spontaneously recover, and there will be 100% recovery. Examples I have given, and the treatment till it recovers would be a splint. Give them a splint, because this splinting would prevent contracture of the muscles. Alright, okay, clear so far, good. So neuropraxia is nothing but Sunderland type 1. Now what is axonautomesis? In axonautomesis, friends, axon is injured. Axon is injured now. Axon is actually getting injured. Now axon, I told you, is surrounded by endo, peri and epi. Now, if only axon is injured, you call it Sunderland type 2. If axon with its endo is injured, you call it 3. If axon with endo and peri is injured, you call it type 4. Because what happens when axon, endo, peri and epi is also injured? It means all the structures are injured. Then it will become type 5 or neurotomesis. Hai na? Simple, hai na? Right. So look at this. All are structured, injured. All structures are injured. Type 5, neurotomesis. All are spared, only physiological conduction block, neuropraxia. Only axon injured, type 2. Axon plus endo is injured, type 3. Axon plus endo plus peri is injured, type 4. Clear hai? Right. Now what happens when the axon is injured with a few sheaths around it? At least one sheath will remain intact. What will happen? Now since there is an injury to the axon, there will be a neuroma. Which type of neuroma? End or neuroma in continuity? Yes, there will be a neuroma in continuity. So axon is injured, but the nerve continuity remains intact. There will be a neuroma in continuity. Right. So when there is a neuroma in continuity, let me ask you, TNL will be positive or negative? TNLs will be positive. Progressive or non-progressive? TNLs will be progressive. And what will be the rate of regeneration? 1 millimeter per day. Wow, you know this. You already know this. And obviously, since the neuroma is regenerating at the rate of 1 millimeter per day, we'll also see motor march. Also, remember, there is an MCQ then. Motor march will be seen in neuropraxia, axonautomesis or neurotomesis. All. The answer is only in axonautomesis. It will not be seen in neuropraxia because there is no neuroma. And in neurotomesis, there is no regeneration. Simple, Anna, right? So if you know your basics, you know your structure, then everything starts to fall into place. Now, the injuries that usually give you axonotmesis are your typical fractures and dislocations. Okay? Now here, recovery will happen progressively from proximal to distal, but it will take time and it will never be 100%. So, spontaneous recovery, 100% recovery, neuropraxia. Progressive or gradual recovery from proximal to distal and never 100% is axonotmesis. And finally, in neurotmesis, you will get no recovery because the whole nerve is injured, right? So axons plus all the sheets are injured. And since all the sheets are injured, friends, what will happen? What will happen? There will be an endoneuroma. And if there is an endoneuroma, there will be positive but non-progressive tinel. So positive but non-progressive tinel. There will be absolutely no recovery unless you repair the nerve. We'll talk more about it later. You will have to repair the nerve. When do you get this kind of injury? Whenever there is an obvious cut, right? So like a laceration or an open wound or an incised wound, okay? In these kind of injuries, you will get an obvious cut of the nerve, right? Okay? Have you understood the classification of nerve injuries? You've understood Seddon's and Sunderland's. So far, these nerve injuries can be classified, right? And they can be tested. How can you test them? Clinical test, you only know one right now. You know Tinel's test. So Tinel's test is the clinical test that will help us assess whether the nerve is recovering or not. That is the only purpose of Tinel's test. Tinel's test just helps us know whether the nerve is recovering or not. Nothing else. No other information can be gathered with a Tinel's test. Nerve is recovering or not? Yes, Tinel's will tell you that. So what is the investigation of choice for nerve injuries? The investigation of choice for nerve injuries, which will give us more information in terms of where is the nerve injured, what type of nerve injury it is, and whether the nerve is recovering or not. All this information will be given to us with the help of nerve conduction studies, which is the investigation of choice. And in nerve conduction studies, remember, there are two parameters. One is the nerve conduction velocity, the velocity or the speed at which the impulse is getting transmitted through the nerve. Other is electromyography, the response of the muscle based on the stimuli of the nerve. What do you need to know? That nerve conduction velocity is the best component of the nerve conduction studies, and electromyography shows changes earliest. Whether the nerve is recovering or not, it will be picked up early on electromyography. Okay? So these are your basic MCQs in terms of the classification of nerve injuries. Now coming to the general treatment of nerve injuries. I've told you most of the nerve injuries are neuropraxias because seen in compressions. Okay, seen in compressions. So when these nerve injuries come to you, you don't have to worry. You manage them conservatively. What do you use? You usually use a splint. So for example, you have a wrist stop, you will use a cock-up splint. You have claw hand, you will use knuckle bender splint. All these splints we'll discuss later. But general idea here is to manage conservatively. Now if there is an injury to the nerve, which is more than your neuropraxia, then you will have to decide what to do. Whether you should wait for it to recover or whether you should intervene, explore and repair if required. So when will you go for exploration of nerve injuries? I have an algorithm prepared for you to make your life easy, but look at this now. Suppose a patient comes to you with a closed fracture. What is a closed fracture? Where there is no obvious wound over the fracture. And when there is a fracture, say a nerve is injured. Usually the injuries are neuropraxia. What do? You splint for the fracture. You reduce the fracture and splint for the fracture. Now, at the time of splinting, if at the time of splinting, you have manipulated in such a way that the patient's nerve is impinged between the fracture fragments, the patient will immediately show you nerve injury manifestations. Immediately, at the time of reduction. If that happens, it means that you have, while manipulating the fracture, injured the nerve. If you have injured the nerve, then you go for exploration. Immediately. Are you following me? This is different from a patient who has injured the nerve at the time of the fracture. Why is this different? Because at the time of the fracture fragment would have injured the nerve and the fragments usually come back to their normal anatomy without further injuring the nerve. So it's a neuropraxia, and since the fragment is moved away from the site of nerve injury, the nerve will recover. But while you're manipulating for the fracture to reduce it, there is a high chance that the nerve will be sitting between the fracture fragments, and that is why it has injured right now when you are manipulating it. Are you following? Two scenarios here. If injury hai, and because of that injury there is a nerve injury, because of that fracture there is a nerve injury, that is neuropraxia because of the fracture, don't worry about it, it will recover. But patient came to you with a fracture, but there was no nerve injury, and you, while manipulating for the reduction, have caused nerve injury, then go for exploration. Are you following me? Okay. So for example, a patient has a fracture, and because of the fracture, there is a nerve injury. Just do the closed fracture management with a splint and then observe. If after observation, the nerve is recovering, great. If it is not recovering, go for nerve conduction studies and see whether the nerve is recovering or not with the help of nerve conduction velocity and electromyography. If the nerve conduction velocity and electromyography is showing that the nerve is recovering, great. If it is not showing any kind of recovery weeks or months later, then you can go for exploration. Following me? Right? Taken a very simple. Fracture, neuropraxia, splint, wait and watch. Recovering, greater. If not recovering, nerve conduction studies. If recovering, great. If not recovering, explore. Simple. Eh? Now, closed fracture, no nerve injury, but you while manipulating cause nerve injury, don't wait. You have injured the nerve right now. Go and explore. So far so good? Right. Now, for example, there is an open fracture. There is a fracture which obviously tells you that this fracture will definitely injure the nerve. Somebody took a sword and cut you. Suppose somebody hit you with an axe. There is a fracture and obviously sharp object was used. So very, very high chances or obvious reasons for the nerve to get injured. So if there is an obvious nerve injury or there is an open fracture which suggests that the nerve is likely to get injured, don't wait out. Because you know that the nerve is likely injured, go for exploration. Kuch samajha? Did you understand here? Did you understand this algorithm that I have prepared for you? It's very simple. Closed fracture, neuropraxia, wait and watch. Open fracture or any injury that obviously tells you that the nerve can get injured underneath it, explore. Okay, try to run through this when you try to answer MCQs. Okay, now suppose you know that there is a nerve injury. How will you attempt to repair and what are the types of repair and what are the outcomes of those repairs? Let's see that. So types of repairs of the nerve depends on the duration after the injury. If you repair it within the 6 hours, we call it primary repair. This is usually done for nerve injuries associated with very clean-cut injuries. 7 to 18 days, delayed primary repair. These are for wounds that are not very, very neat and clean. And then there is a secondary repair that is done 18 days later. This is done because there are other problems that need to be addressed first. You just need to remember the durations for the sake of your MCQ. So primary repair, delayed primary repair and secondary repair of nerve. Now how do you repair the nerve? There are 2 ways of repairing the nerve. You can approximate the cut ends with each other. So that is end-to-end repair. Or you can do a end-to-side repair. Obviously, end-to-end will be better. End-to-side will not give you a great outcomes. So end-to-end is preferred. Now, sometimes what happens when the nerve is injured, the nerve fragments move so far away from each other and they cannot be approximated. In those cases, you need to put a graft. You need to put a nerve graft in the middle so that you can repair them. Sometimes, not in the recent past, sometimes they have asked MCQs, which nerve will you use as a graft? The most commonly used nerve is the sural nerve, other is saphenous nerve. This will help you answer a few MCQs. Now, in terms of the outcomes of nerve injuries, I want you to understand the prognosis of nerve injuries. Okay, so what are the good prognosis parameters for any kind of nerve injuries? Obviously, of the 3 types of nerve injuries, where is neuro, axo and neurotmesis, which type of nerve injury will have better prognosis? Neuropraxia. Neuropraxia always has better prognosis. If you do early repair, the prognosis is good. Radial nerve injuries usually have the best prognosis of recovery. And I'll tell you why later on. If the vascularity of the nerve injured is intact, obviously the outcome will be better. And if you do an end-to-end repair compared to end-to-side repair or without using a graft, the outcome is better. And if it's a child, definitely the outcome is better. A simple way to remember is the mnemonic nerve, N-E-R-V-E, is growing. If you remember this mnemonic, this is the mnemonic for good prognosis of nerve injuries. And remember I told you, radial nerve has the best prognosis of recovery. The reason for this is because it's mostly a purely motor nerve. Mostly, because it has a small sensory component also, but mostly a purely motor nerve. This gives us the best prognosis of recovery. And the reason for it is mixed nerves. See, mixed nerves have sensory and motor component. And when they are injured, the sensory axons may repair with the motor axons and the motor axons may heal with the sensory axons. This is what is known as your axonal confusion. And because of this axonal confusion, a sensory stimulus may give you a motor response, and a motor stimulus will give you a sensory response. So this will not be a very good recovery of any kind of nerve injury. So mixed nerves usually have poor prognosis of recovery. For example, say your sciatic or ulnar nerve, they have poorer prognosis of recovery compared to your radial nerve, which is a purely motor nerve. Okay, is that clear? Have you understood the basics of nerve injuries now?